the issue itself. The case I'm told is that of an ectopic pregnancy, so we will have some time to take into account various aspects of ectopic pregnancies subject. So Dr. Sarish, who is a second year resident at Hamidri Hospital, is going to make this presentation. Is it a case presentation or topic of the topic? All right, sorry. It's a topic of ectopic pregnancy.
Today I'm going
आप इधर आ जाओ, आप या बल्कि इधर आ जाओ जहाँ पे मैं बैठा हूँ, मैं उधर चला जाऊँ.
Assalamualaikum, I'm Dr. Sarish, and today I'm going to present ectopic pregnancy. Definition. Ectopic pregnancy occurs when a fertilized egg implants and grow outside the cavity of uterus. Most often occurs in fallopian tube. This is the picture of ectopic pregnancy, which is implanted in the fallopian tube. Risk factors of ectopic pregnancy includes history of previous ectopic pregnancy, pelvic inflammatory disease, chlamydia infections, history of smoking, and increased maternal age. This is another picture. The picture on the right side shows ruptured ectopic, and on the left side, tubal abortion. Differential diagnosis includes ruptured ovarian cyst, adnexal torion, endometriosis, appendicitis, perforated ulcer, acute pancreatitis, and intestinal obstruction. Clinical features of ectopic pregnancy includes the triad, which is abdominal pain, amenorrhea, and vaginal bleeding. Most important symptoms of ectopic pregnancy is adnexal tenderness, which is aggravated by moving the cervix sideways. And on examination, abdomen may be non-tender before rupture, but after rupture, abdomen may be distended with marked tenderness, vowel sound decreased or absent. On pelvic examination, cervical motion tenderness may or may not present, commonly seen after rupture.
Okay, sorry. इस स्लाइड पे क्या हम दोबारा है?
Investigation.
ठीक है.
The most important investigation for ectopic pregnancy is transvaginal ultrasound. First one is the transvaginal ultrasound. The second is beta human chorionic gonadotrophin, and third the CBC. On transvaginal ultrasound, which is the diagnostic tool of choice for tubal pregnancy, its sensitivity is 87.0 to 99.9%. The serum beta human chorionic gonadotrophin level is useful for planning the management of an ultrasound visualized ectopic pregnancy. And in homogeneous or non-cystic adnexal mass is the most common finding in around 50 to 60%. An empty extrauterine gestational sac will be present in around 20 to 40% of cases, while an extrauterine gestational sac containing yolk sac or embryonic pole that may or may not have cardiac activity will present in around 15 to 20% of cases. Number 4, 20% of cases may have collection of fluid within the uterine cavity. Management. For management, expectant is medical and surgical. First, we will discuss expectant. Expectant is for those who are hemodynamically stable, and if their beta HCG is less than 1500. Expectant management is a reasonable option for appropriately selected and counseled women. They must be willing and able to attend for follow-up, and they have minimal pain and lower declining beta HCG level, reported success rate from 52 to 100%. Change the medical management. Medical management includes the methotrexate at a dose of 50 milligram and has been widely used as a single dose, and it is the most commonly used drug. and we will advise beta HCG on day 4 and 7. Indications of methotrexate: when the patient is hemodynamically stable, low serum beta HCG, initially less than 1500 but can be up to 5000. No fetal cardiac activity and willingness to attend for follow-up. And contraindications of methotrexate includes intrauterine pregnancy, evidence of immunodeficiency, moderate to severe anemia, sensitivity to methotrexate, hepatic dysfunctions, and renal dysfunctions. Regime. Single dose regime includes on day 1 methotrexate 50 milligram intramuscular given, and day 4 and 7 we will advise beta HCG to measure the level of beta HCG. 3. A rise may be seen on day 4 compared to the baseline day 1. If it is greater than 15% drop from day 4 to day 7, continue to follow weekly until beta HCG level less than 5 ml. If it is less than 15% drop from day 4 to day 7, repeat methotrexate and then repeat beta HCG on day 4 and day 7. Side effects of methotrexate includes bone marrow suppression, pulmonary fibrosis, liver cirrhosis, renal failure, and gastric ulcer. Surgical management is applied for those patients who are hemodynamically unstable or with profuse bleeding. The patient is not a suitable candidate for medical therapy. Medical therapy has failed, and the patient has heterotropic pregnancy with a viable intrauterine pregnancy. In the presence of healthy contralateral tube, self-injectomy should be performed. Indications of self-injectomy include childbearing completed, second ectopic pregnancy in the same tube, uncontrolled bleeding, and severely damaged tube. Indications of self-injostomy: in women with history of fertility reducing factors, previous ectopic pregnancy, contralateral tube damage, previous abdominal surgeries, pelvic inflammatory disease, self-injostomy should be considered. And if self-injostomy is performed, women should be informed about the risk of persistent trophoblast with the need of beta HCG level follow-up. They should also be counseled that there is a small risk that they may need further treatment in the form of systemic methotrexate or self-injectomy. Thank you.
खत्म हो गया यानी ऑडियंस को बहुत दूसरा ठीक है that is all
thank you.
No, you made a short work of what I thought would be a very long subject, but this is a short summary of ectopic pregnancy. हाँ स्लाइड बंद कर दें, वो क्वेश्चन आंसर वाला एरिया भी खोल दें, कमेंट ताकि लोग जो है कर लें. मेरा ख्याल था कि ये केस प्रेजेंटेशन होगी तो वो फिर हम करेंगे क्योंकि रिसेंटली वी हैड फ्यू केसेस ऑफ एक्टोपिक प्रेगनेंसी और वॉइस अभी तो एको नहीं कर रही. ठीक है क्योंकि if there should generally be a case presentation, and we did only day before yesterday I had a patient who came with ectopic pregnancy and I thought maybe you had taken her history and then we would have been this kind of presentation and can follow a case presentation. Now ectopic pregnancy is not an uncommon occurrence. We all know that we do not really know the incidence in Pakistan, but the incidence quoted in books is how much is the incidence quoted in books? Anyone? कोई भी नहीं पढ़ के आया हो? कितना इंसिडेंस है ectopic pregnancy को? ये लिखो साथ साथ सवाल जो तुमने पढ़ने हैं, कम से कम तुम लोगों को इतना पता होना चाहिए कि एक्टोपिक प्रेगनेंसी का इंसिडेंस कितना है. generally written in the textbooks, quoted incidence is 1.5 to 2%. In UK, because they have that confidential inquiries every 3 years, the incidence in UK was quoted as 11 cases per 1,000, which is 1.1%. And although in UK the services are very well established, primary health care, etc., diagnostics, still in the period in 3 years from 2006 to 2008, there were 6 maternal deaths caused by or because of ectopic pregnancy, misdiagnosis of those who had obviously excessive hemorrhage. Even in UK in 21st century, there were 6 deaths in 3 years' time, whereas total mortality there is about is in single digits per 100,000 live births. So that just shows, and it is considered to be one of the common causes of maternal deaths in first trimester, ectopic pregnancy. So that is the kind of significance that it has. And if you look at our population, where majority is in rural areas, still, or who do not have access to health care facilities or expert health advice, the mortality, I'm sure, is or would be quite considerable. Now, in many instances, an advanced case of ectopic pregnancy is something that you can, just on seeing the patient, you can say that yes, she has an ectopic pregnancy. So therefore, if you see a young woman and she is pale and she is pain abdomen, you can make a diagnosis of that. And then the importance of history in such cases is such that generally it is one of those cases, the diagnosis of which can be made on even telephone. The patient telephones you and she says that she has missed her period, she's overdue by 2 weeks, her pregnancy test is positive, but she has the lower abdominal on right or left side, which is sharp. The immediate thought that would come to your mind would be about pregnancy, and you would want to confirm or rule it out. And nowadays, with the availability of transvaginal ultrasound, it is something which is so convenient and so easy. So you don't have to carry out or go through that routine of history and physical examination. When Sarish was putting up that slide in which she said that you do pelvic examination and you do that movement of the cervix, the rocking movement of cervix, that used to be a typical and diagnostic sign of ectopic pregnancy. Because when you move the cervix to right, or you move the cervix to right of the mother, the right appendage that gets stretched, and she will complain of pain. And if you move it to the left appendage would be stretched. When you move the cervix to the left appendage, left tube and ovary, they will be stretched, and that will give rise to pain. But nowadays, and then, another thing that in older days was used to be practiced was that you would advise examination under anesthesia to make a diagnosis, so that patient's tenderness would not be hindering your assessment that you will be able to palpate a mass in the lateral fornices. But it was specifically advised not to do, because under anesthesia the patient wouldn't have felt pain, and what you could do while palpating within the fingers in the vagina and the lateral fornix and the hand placed over the abdomen, that you could rupture an unruptured pregnancy and not even realize that. So the patient is not in a state of to protest or provide the guarding which would naturally come. So that was even at that time when ultrasound was not available. Now, with the presence of ultrasound, it is something which is quite easy. Beta ICD became available in Pakistan after 1985, in late 80s. Before that, we didn't have the facility of beta SCT, serum beta SCT estimation. So now beta SCT estimation, transmit an ultrasound, coupled with a bit of history, this is something which is the diagnosis is not difficult at all. But still, it presents some clinical dilemmas. Now, you also need to mention what are different types of ectopic pregnancy. You see, the management of those, when you look at the different types, there are the commonest sites, of course, is the tube. And within the tube, what are the areas? So, and say ampullary portion is the most common one. Fimbrial, very rare, and ischemic portion is comparatively less common, but it is more dangerous because of the narrowing tube. It has greater incidence of rupturing early, and then the interstitial, because these are the four parts of the tube in which one can have ectopic pregnancy. Interstitial is the least common of them all, but it has certain diagnostic features which must be taken into consideration. Then it can be in the cervix, it can be in the ovary, it can be in extra horn, or what is called as cornual pregnancy, and it can be abdominal. So these are various types of ectopic pregnancy that can be there. And then since 95% of the times it is in the tube, therefore you generally would say it's when you say ectopic pregnancy, it means that you are referring to the fallopian tube. It is tubal pregnancy. And if it is not there, it's not in the tube, then you have to be more specific whether it is likely to be an ovarian. You cannot, until and unless you see on laparoscopy that the pregnancy, or at laparotomy that the pregnancy is attached with the ovary, because through ultrasound now you can to some extent. Similarly, cervical pregnancy is again the diagnosis of which can be made, and you should know what are the characteristics of ectopic pregnancy to be diagnosed, or if it is a cervical pregnancy. And similarly, there are characteristics of cornual pregnancy, characteristics of interstitial pregnancy. So you should know about those. What are those in which you will find some myometrium, and those in which you do not find myometrium, and you find it that the uterine cavity is, for example, in interstitial pregnancy, uterine cavity you can find and you can identify and delineate quite clearly. And you also see in one corner a pregnancy sac. And if you carry you move the probe, probably you will follow the tube, but tube as such will not be visible. So therefore, if you find that the uterine cavity is regular, there is no other horn, and there is a sac in the corner, then you would say that it is. And then there is another thing which is called when you talk of ectopic pregnancy, PUL, pregnancy of unknown location. So until and unless you identify and you can find, so many pregnancies of unknown location would, on subsequent assessment at ultrasound, would be found at some place in the tube, the uterine cavity, in the cornu, or somewhere. And many of those turn out to be intrauterine pregnancies. So pregnancy of unknown location is also something which comes into consideration, and the diagnosis is made on PUL would be when beta SCT is raised, but you can't find a pregnancy sac. You don't find a mass in on the sides of the uterus as well. And obviously then you follow up and you go on with that. And another variety is heterotopic pregnancy. Heterotopic is when there is a pregnancy within the uterus, and then there is a pregnancy outside the uterus. And that obviously brings into focus certain dilemmas in management. How do you proceed with that? That would, of course, depend upon the status of the intrauterine pregnancy. whether there is fetal cardiac activity present or not, fetal pole, fetal cardiac activity present, absent, etc. And according to that, then you go along with that. Injection methotrexate, so far as the treatment is concerned, that is generally you should know, because when you were showing the slide, it was 50 milligram per square meter of body surface. So you need to know how do you calculate that. So it is not necessarily 50 milligrams across the board. And then 1 dose, 2 dose methotrexate. And the significance of serial estimation of beta ACT. Because if there is that serial estimation, then how much should it be decreasing? Generally, when you administer methotrexate, you would have baseline beta ACT levels, and then you follow that up after a few days. Generally, recommended regimes are day 4 and day 7. So if you find that on day 4 it is at a certain level, and then you again do it on day 7, then what should be the generally rate of decline of beta ACT levels, which would indicate that there is resolution of ectopic pregnancy, and then you will of course follow the patient on a weekly basis with beta ACT estimation. So that kind of so dosage of methotrexate, follow-up of methotrexate, how you are going to do, and even before dosage, you should also consider the criteria at which you will give methotrexate. And those pregnancies in which methotrexate management or expectant or medical management will not be suitable, and you should go straight forward for surgical management. And in surgical management, so expectant management, as you said, expectant management is one in which the beta ACT levels are too low. You find that there is suspicion of ectopic pregnancy on the side, and you repeat beta ACT after say 3-4 days, and you find that beta ACT is coming down, and of course the patient is compliant, and she will report to you immediately if she has features of pain, etc., which would indicate that the things are aggravating. But if those are not happening and beta ACT is falling, then you may not even give methotrexate. But that is if the initial levels are low, as you probably showed that they were 1,500 or below that. So that would be the criteria. But if it is more than that, then methotrexate. But when you give methotrexate, you should also know what investigations would you do before administering methotrexate, and then what are the side effects of methotrexate. I personally am very scared of advising a second dose of methotrexate because of its side effects. Although you will come across in literature dosage in which routinely they gave 2 doses, and then there are instances in which multiple doses of methotrexate are given. But then you should know what are the side effects which the patient can have, and you very appropriately put up those, because most of it's a kind of drug which has effects on major systems like bone marrow suppression. It has effect on lungs, it has effects on liver, kidney, etc. So it has multiple side effects. So that's and then when you talk about the surgical technique, laparoscopic or laparotomy, the important thing in that is that you must know, the person who's performing surgery should know their limitation, whether they can perform laparoscopic surgery or not, and if not, then they should go for laparotomy. And at laparotomy, an approach is that you would first inspect the contralateral side and see what is the status of that tube and ovary. If there is ovary present, the tube looks normal, then you can remove the tube or perform what is called as salpingectomy. But if it is not, then you would perform salpingostomy. You would just open up the tube and on the area where the pregnancy is, milk it out, or with hydrodissection. Generally, you don't push it out. you remove the pregnancy sac with a hydrodissection, as it is said, and so that there is minimal disturbance of the vascular apparatus around the pregnancy, so that you don't have to employ means to arrest bleeding from that area, or there should be minimal intervention. And occasionally, once in a while, you may save a tube like that, which later on becomes of use, which is of use later on. So that is the kind of approach that you would take. And of course, it was previously recommended and would be recommended now also that at the end of the surgery, then you remove all the accumulated blood and clean the cavity, etc. Then there is another condition which is called chronic ectopic pregnancy, when an ectopic pregnancy has been either managed conservatively or managed medically, and there is bleeding, or the patient presents to you with features of having had ectopic pregnancy, but then she presents and she comes with irregular bleeding. On examination, you find that there is a boggy mass in the pouch of Douglas or posterior to the uterus. And on physical examination as well as on ultrasound examination, that is usually collected blood, which is known as hematocele, collected or sequestrated blood, which gets a kind of covering all around. And in that case also, laparotomy or surgery is required, because you remove that and you ensure that hemostasis has been secured. Sometimes these cases, they have small trickle of blood coming out from that ruptured ectopic pregnancy. So this is a general overall approach to ectopic pregnancy. Now I would welcome the questions from you or from the audience on the.
So if there is collected blood in the baby, can we also do ultrasound guided aspiration? It is not that much.
That well, if it is the content is fluid, that you can do, but usually it is organized. There are blood clots, or it's an organized hematoma, and that you cannot remove by ultrasound guided. You can't aspirate that.
So it means that the hemostasis has not been secured well previously, which is why
it happens not really in those cases which have been operated, but because the blood loss was occurring at minimal kind of pace, and it accumulated without aggravating the patient's general condition, which would have warranted the patient to seek medical advice immediately. So she comes with a pain in the lower abdomen for some time, and if you take proper history, then there would be history suggestive of antecedent pregnancy, and maybe she would have complained of some discomfort, extra discomfort or pain in one of the lower abdominal sides, left or right, and then coupled with that, the presence of that mass.
So what is the gold standard investigation?
Yeah.
The gold standard investigation is an exam.
Gold standard investigation, you see, these days transvaginal ultrasound is pretty much, I would say, gold standard. You see, now I'll give you a little bit of perspective. Probably I mentioned on a previous occasion, when I did my FCPS, at that time we did not have ultrasound. We had only, we had laparoscopy, and laparoscopy, diagnostic laparoscopy, was not available everywhere. At that time, diagnostic laparoscopy was quoted to be the gold standard of investigations, because one of the examiners asked me that, why don't you do culturesynthesis? You push in a needle into the posterior fornix, and if there is blood coming out, that would show that there was ruptured ectopic pregnancy. And whereas one would have made that diagnosis of ruptured ectopic pregnancy on clinical grounds, and to wait till or for that to happen, that blood to accumulate in pouch of Douglas, that would be a little late. But that was a sign that you do culturesynthesis, you aspirate that, and you find blood. And as I said, laparoscope was gold standard. But with the advent of transvaginal ultrasound, which became available in the 80s, and with the accuracy that you can find that there is now, and addition to that, Doppler. Now you can see the vascularity of that sac, and you also now can visualize sometimes the fetal heartbeat. And therefore, now the gold standard, I would say, is transvaginal ultrasound. और से ना ये टॉपिक पे जब बात करनी है ना तो उसका टॉपिक के साथ तो केस की हिस्ट्री मैं पूछ लिया करो, कोई ना कोई पेशेंट होता है मैं तुम लोगों को हिस्ट्री दे दिया करूँ, वो बना सकते हो आप उसको, ठीक है। कहाँ से पढ़ा था तुमने?
मैंने गाइडलाइन से पढ़ा था।
और ये मैं 2-3 पॉइंट्स हैं आई वुड वांट टू kind of advise all of you who are preparing for the examination that there are various guidelines available on many topics. RCUG guidelines are, so far as I know, they are freely available on the net. You can get them. So all those guidelines, and they are updated from time to time. So you should be aware of RCUG guidelines about the subject. American College of Obstetricians and Gynecologists, they also have guidelines, but those are not always available free on the net. But their summaries are, so you can have some of those. And then internet has made things so easy that you can get access to so much of material which doesn't really leave you in want of something more, because there is so much that you can kind of get swayed by it. So you need to limit yourself to what is actually relevant and necessary and what is authentic. So, and second thing I would say is that from all of this, that you should make your own notes about it. That what are the features of that. Now, there is one particular type of ectopic pregnancy. We can call that ectopic pregnancy, which I haven't mentioned, and that is nowadays diagnosed cesarean scar pregnancy. So cesarean scar pregnancy is again something which is important and is of clinical importance in as much as because it can result in excessive blood loss and may potentially require removal even of the uterus. And the bleeding which happens at that sometimes with this is really frightening. Recently, Rugina had a case of cesarean scar pregnancy. Yes. And she performed MBA with all the preparation, etc., with blood arranged, etc. But there are, and perhaps methotrexate had already been given. So there is now a protocol of that. I can share with you a couple of slides about cesarean section scar pregnancy management. Google Meet पे मैं इधर से आ सकता हूँ अपने अकाउंट से, RLMC वाले अकाउंट से, उसमें मैं हूँ। काम क्या ग्रुप का नाम है? What I'll do is that I will forward those slides and some of those papers which I think are relevant to you on your group, trainees group, and then you can share it with the rest of them on the larger group. But this is what is required that so far as medical management is concerned, the criteria for medical management, the dosage schedule, and how to monitor that. That's important. And of course, the methotrexate complications. These are the points that you need to be confident about. Then various types of ectopic pregnancies, their differentiating features, and how you diagnose them.
So when we send investigations, we need to send complete blood count, LFTs, RFTs.
वो हो गया. मैं अब वो बात कर रहा हूँ कि अब various types of ectopic pregnancy क्या हैं, उनकी diagnostic features क्या हैं. इस तरह से वही interstitial की, cornwall की, cesarean section scar की. I had an article which is ultrasound for diagnosis of ectopic pregnancy in probably in an ultrasound journal, and that gives pictures of these various types. For example, there is this sign that there will be absence of sliding sign in case of cervical pregnancy. So that gives pictures of those, and also that also provides some examples or explanations. So you can look at that and you can have those pictures. So that's important. So various types and their distinguished features and their points of identification or diagnosis. And surgical approach, laparoscopic or laparotomy. And then what are the laparoscopic approach features, or at laparotomy what would you do? Another one which needs a little bit of explanation is abdominal pregnancy, which is uncommon, extremely uncommon, but still you can come across that. And how to go about it, you read that up. Laparoscopically, laparotomy, at what stage would you do what, and would that be preceded by a dose of methotrexate? And similarly, in those pregnancies in which, for example, cesarean section scar pregnancy, in which you would bring about fetocide by injecting either methotrexate into the sac or by injecting calcium chloride, that you can do. So first do that so that you reduce the vascularity, and then, but these are various areas which you need to look after yourself, make your own notes and prepare that. Or if there are any questions or there are comments, please. अगर नहीं है तो कर देते हैं. ठीक है, चलो, ओके.